The predictors of events were a plaque burden more than 70%, a VH TICVA, of course VH is no longer a viable technology, and a lumen area less than 4 square millimeters. The importance of a plaque burden is highlighted in this data from the MGH combining IVUS and OCT, showing that a plaque burden of, again, more than 70% was a strong predictor of culprit rupture versus non-ruptured culprit lesions. The next study was the CLIMA study, which was an LAD study from Italy, and the CLIMA criteria were a fibrous cap thickness less than 75 microns, OCT-defined macrophages, lipid arc more than 180 degrees, and a lumen area less than 3.5. And if you had all three criteria, the event rate was much, much higher than if you did not have these criteria. The next study was LRP, which came out of Ron Waxman's group, where the predictors of events were a maximum LCBI more than 400, a plaque burden more than 70%. Again, that number keeps coming up over and over and over, and a lumen area less than 4 square millimeters, very similar to the Prospect 1 criteria. And if you look at the patient level and segment level non-culprit MACE, you can see that an LCBI of 400 doubles your event rate of both a patient level and in a lesion level, it increases it by 4 times. Then we come to the fourth study, Prospect 2, which was another natural history study, but there was embedded within Prospect 2, Prospect Absorb, in which lesions were randomized to absorb BVS plus medical therapy versus guideline-directed medical therapy. Very similar, we have a max LCBI more than 325. This is the upper quartile. Again, a plaque burden more than 70% and a lumen area less than 4 square millimeters. And if we look at the patient level and lesion level events based on a plaque burden of 70% or more, a tripling of the patient level events and a 10-fold increase in the lesion level events. Again, highlighting how important is the plaque burden. In terms of max LCBI of 325 or more, a doubling of events at a patient level, and an increase of by almost 10-fold of events at a lesion level. And then when you take the Prospect 2 lesions and you stratify them by the presence of a plaque burden more than 70% and a large max LCBI, that's where the events occur. The absence of both of these two usually predicts quiescence. And I like this spline analysis of plaque burden and max LCBI from Prospect 2, and you see that the increase of plaque burden exponentially increases the event rate, as does the max LCBI. And then about Prospect Absorb, Greg Stone always shows this slide, that BVS is associated with a better outcome compared to medical therapy alone, with no increase in adverse events. Okay. So all of that data that I went through very quickly comes to the following conclusion. We can reliably predict a vulnerable plaque. And you can argue whether you want to use OCT or want to use NIRS IVUS, but we can reliably predict vulnerable plaque. Now comes the giant but. So what is really the event rate in these studies? What are we trying to prevent? If you look at the annualized overall rate of non-culprit death, cardiac arrest, or spontaneous MI, the event rate is really extraordinarily low when these patients are treated medically. Secondly, when you're doing 3-vessel imaging, you only detect half of the lesions that cause events. You miss 50%. Why? Because it's in a branch, or it's a distal vessel, or you had trouble getting into the circumflex. So your imaging success rate is only 50%. And your positive predictive value is in the single digits. So what are we really accomplishing, chasing after looking for a vulnerable plaque? The answer is not a whole lot. And of course, there are complications. They're not high, but the complication rate in Prospect 1 was 1.6%, LRP was 0.4%, and Prospect 2 was 0.2%. And if you look at Prospect Absorb more closely, yes, The lumen area was bigger in the absorbed group because you placed a stent and you dilated the vessel. But if you actually look at the cumulative frequency distribution curves, they are frozen in both groups. In addition, the majority of tikvas either heal, develop a thick fibrous cap, remain stable, or rupture silently, leading to disease progression and a larger plaque burden rather than to death and myocardial arrest. Coronary atherosclerosis does not grow slowly like walking up a ramp. It grows by plaque rupture healing, and plaque rupture healing like you're walking up steps. And of course, new tikvas can develop. This is a landmark paper that people don't recognize enough. It's 20 years old. It's from Renu Vermani's group. 142 patients, men with sudden cardiac arrest, had a total of 475 underlying healed plaque ruptures that never caused a problem. And they only had 44 acute plaque ruptures, and the number of underlying healed plaques was associated with a larger plaque burden. And then if you do serial imaging studies, you can see that of 100 tikvas at baseline, 60% heal spontaneously, 40% persist, and at the same period of time, which is about 6 to 12 months in these studies, you have 53 new tikvas develop. What does medical therapy do? Well, this is an elegant article from Steve Nichols. We simply looked at the reduction in LDL versus the annualized increase in fibrous cap thickness. You put a patient on adequate medical therapy, the fibrous cap thickness increases, and the lesions become stable. And finally, there is no data on predictors of plaque erosions likely to cause events. In our experience, erosions are increasing in frequency, particularly in older patients, and there are no predictors of the first episode of a spontaneous coronary artery dissection or of a calcified nodule. So I was asked a question, vulnerable plaque detection and therapy, is it the future? And quite frankly, I'm not sure. It sounds great. It sounds great that we prevent people from having sudden death. But the numbers, the statistics, really do not make sense. And it really does not make sense to go searching for vulnerable plaques, particularly when we have such excellent medical therapy today. Thank you for your attention.